dysmorphic baby. It will not be a lecture about the genetics. It will not be lecture about the syndromes. It's actually how to, if you found a baby that you doubt is dysmorphic, how you will approach him. So it will be some example from the syndromes, but it will not be mainly about the syndromes. It will be about the whole approach from the history and physical examination. I will start now. So my objective, we'll start with introduction. We need to go over the definition, important definition, the history and physical exam, and diagnostic tests. Okay, introduction. Congenital anomalies usually present at birth, and it could be caused by either genetical abnormalities or an environmental exposure, or sometimes unknown causes. It can be isolated and or can be present in a combination or a certain pattern, and this could affect one or more organ. To evaluate a child with birth defect, you have to go in a comprehensive start of history, physical examination, and also you need eventually the lab evaluation. Now, important thing to differentiate, an important thing to know actually, what is a congenital anomaly? This is the first thing. What is the definition of congenital anomaly? How to classify any congenital anomaly? And then the most important thing is that we say syndrome. What is the syndrome? And what is the classification for any birth defects in general? Now, anomalies, it's actually either major or minor. You say it's a major anomaly when it's any birth defects that interfere with the normal function of any individual and pose significant health problem. Something like congenital heart disease, any neural tube defect, cleft palate. Now, the other thing is the minor anomaly, and usually this do not interfere with the normal function of the individual. It's mainly cosmetic significant, something like semen increase, accessory nipple, auricular skin tag. It's something that is cosmetically, it's not, it's not well, it has a cosmetic significance, but function-wise, it will not affect the baby. Now, classification of birth defects in general. We know the main classification. It's either malformation, and it's a primary developmental defect. It's usually caused by genetic environment or multifactorial, and recurrence risk varies. It occurred during the period of organogenesis, which is 8 weeks post-fertilization, something like a neural tube defect and ventricular VSD or polydactyly. There might be recurrence in coming sibling, but it will be as we said, it's varied. Sometimes it will be 3 to 4%, sometimes it will be 10 to 50%. It depends on the anomalies that we are talking about. Deformation, it's a normal developed structure that was distorted from the normal due to mechanical forces, and this is more of a later gestational problem. And mostly it's things that involve the musculoskeletal tissue, something like clubfoot, torticollis, and obligocephaly. Now, the other also is disruption. It's usually breakdown of an intrinsic normal developing or developed tissue to some disruptive event, whether it's mechanical, vascular, infectious, like something like amniotic band sequence. Okay, so you will have sometimes loss of the organs. Yes. Dysplasia in general, it's the abnormal cell organization, and this is something like skeletal dysplasia. Now, syndrome, it's recognized or defined as a composite pattern, 2 or more anomalies with a common specific etiology, something like Turner syndrome. When things are non-random occurrence of 2 or more anomalies, something called association, and it can be expected by chance alone, something like bacterial association. When it's 2 or more anomalies and you have a genetic and specific etiology for it, this is a syndrome. when it's a random or non-random occurrence, 2 or more anomalies, something like Bactral, and expected by chance alone. No known specific etiology for it. Yes. This is for just an example, something like Bactral. We know the Bactral association and what this stands for. But just to tell you that it affects, as you see, multi-organs. It affects GI, the cardiac. It affects multiple organs, but actually there is no certain etiology or certain etiology that you can refer Bactral for. Sometimes it might have a genetic, something like charge, might have actually genetic base for it, but not all charge syndrome or sequence actually have a genetic base for it. Sometimes they have CHD7 mutation. And the other baby is Edward. Okay, this is also to explain something like a sequence. Pattern of anomaly that happen to one primary anomaly, like water sequence. Your primary anomaly usually is abnormal or bilateral renal aplasia, abnormal, basically something abnormality in the renal system, which decrease faces of the patient, water and blood in nose, and deform, and pulmonary hyperplasia. And position abnormal, and usually there is lymph defect, mainly positional, because there is less amniotic fluid to be in. So it starts by one anomaly that caused all these anomalies. This is sequence. Yes. Something like this one, water sequence. Now, how to approach any dysmorphic feature, any actually problem, you have to start with a history and physical examination, and then you go to the other, other type of approaches. And first of all, you have to decide: is there a problem? If there is a problem, what is the problem? And if there is a problem, and you know what is the problem, is there is association with this problem? If there is associated problem, and if you can find a reason, sometimes you cannot find the reason immediately, but you can look for the reason. And how to diagnose, and sometimes, and you want to reach that to know if there is a treatment, or actually to give a reasonable prognosis for the family. Starting with the maternal history, everything is starting from the mother. You have to ask about the mother, the age, because with advanced maternal age, you have certain type of syndromes that's more diseases, diabetes, hypertension, or seizure disorder, because certain anticonvulsant will affect the neural tube defect. Diabetes will affect multiple organs, not only one organ. The mode of conception was natural, what is assisted reproductive technology with fertility medication, which is was it IVF or intracytoplasmic injection. Then you will see the exposure. Was the mother on any certain medication, whether illicit medication or the regular medication? Did she consume alcohol during the pregnancy? Is there any possibility that she had infection during the pregnancy? And if there is any environmental agent, she was exposed to toxin or something, and perinatal tested, you have to see the antenatal ultrasound and the anomaly scan to give you some ideas. The maternal serum screening, the quadruple test in the beginning could help you to assess what type of anomaly might you expect, and the amniocentesis and corneovillus sampling. Now you go to the baby himself, the birth history. How's the baby activity? Fetal activity usually during the antenatal scan. How was the delivery? Was it cesarean? Was it normal delivery? What type of delivery was it? Just the gestational age. How was the Apgar score? Did the baby require any resuscitation? And how was the growth parameters? If you have an anomaly, you have to go to family history and pedigree analysis. You have to make sure if there is identification of relatives with either congenital anomalies, any relative with mental retardation, any previous pregnancy losses, any history of infertility, and you have to take the medical history of the primary relatives. Certain diseases are more in certain ethnicity than others, and consanguinity, as you know, it will increase the risk of especially autosomal recessive and certain type of diseases in families. Before you go to physical exam, you have to make sure that you took all the measurements, the height, the length, the head weight, the head circumference. You see the proportionality and asymmetry, the upper segment, the lower segment ratio, and the arm span. It will be important, especially in skeletal dysplasia. Individual limb segment measurement, and you have to go for the neurological exam and head-to-toe assessment. That's what we go now. This is actually a form they used for mainly if you are looking for any certain genetic disease. They use certain form to just find if there is any abnormality, starting from head to neck to what is in the trunk. Even the space, it's important. For the epicanthal space, intrapubular space, these things you will see it's important to decide if this baby actually have anomalies or you have to go for further assessment or not. You start first of all by physical exam, cranium, any craniofacial anomalies, the eyes, the ear, the nose, the philtrum, the mouth, the spine, the limbs, the skin, hair, and nail. You start physical exam by the cranium, the shape, the symmetry, the suture, whether overriding, normal, widely open, could be already closed, the fontanelle size and number, and the scalp hair as well. Although it will be mentioned later on, but it's important to know the color, the distribution, anterior, posterior hairline. This is important. You have to measure the OFC from beginning. We said this is actually important even before starting the physical exam. You have to know the circumference of the baby to decide if this baby is macrocephalic, microcephalic, normocephalic. Something like craniosynostosis. This is actually, I will not go over this, over that in detail, but just we'll go over it very fast. You know that sometimes the shape will be scabocephaly, where there is a premature closure of sagittal suture. It's not always abnormal, but you have to make sure to follow the regrowth parameter. Something like frontal plagocephaly, which is something that like in acrosome in a birth syndrome. Something like a brachycephaly, like in Carpenter syndrome. A trigoncephaly, and there's occipital plagocephaly. There could be multiple suture involvement, but this is all important to decide. This is a acrosome syndrome, the other is Carpenter. Hairline, if it's the hairline, low hairline, it's something like Cornelia de Lange. Yes, so you have to, as we said, you have to see the hairline, even it's important, it's part of the cranium. The color of the hair is important, something like Menke disease. So the point is just you have to look for everything and look if things looks normal. It could be sometimes their hair type, but high Menke. Now on the face, facial measurements, it's very important. Intrapubular distance, you have to see if there is inner canthal fold, there's outer canthal fold, how much the filter length, how much the upper lip thickness, the lower lip thickness, the intercommissural distance, and compared to age and sex norm. If it's below or more than 2 standard deviation. There's a certain لا ما بوصلها. No, not this one. Okay. I'll go there later on. There is certain measurements where you have actually your normogram for the normal actually distances and the abnormal distances. Okay, so from physical examination in the face, you will start with the forehead. If it's broad, small, tall, there's frontal bossing, there's bitemporal narrowing, there is supraorbital ridge. You will go to the mid face, where is the maxilla. You will see the cheekbone if it's prominent, if it's underdeveloped. You will see the malar region if there is prominence or flattening. You will see the mid face by itself, the nasolabial folds if there's prominent or underdeveloped. The mid face is prominent or protruded. The mandible, the size, the shape, if there is macronathia, retrognathia, if there is prominent jaw. You will see the whole face overall impression of facial appearance. Something like Down syndrome, you will figure it out from looking only the patient. If there is coarse facies like in mucopolysaccharidosis, there is myopathic facies, you could actually make it up with looking to the patient. You could see the shape of the face itself, not the skull. But here we're talking more of the face. If it's triangular, if it's broad, if it's round. Mainly you have to make it into 3 sections: forehead, mid face, and oral region to view front, and you have to view from front and side. Because mid-face hypoplasia, it's better looking at, when you look to mid-face hypoplasia, it's better to be looked at on the side, not lateral profile mainly. You can see here in figure A, this is trisomy 21, this is the enlargement of the eye. You will see in figure C, it's mandibulofacial dystosis, like a treasure column, and you will see actually the colored picture is actually Williams syndrome. And you have the mandibular hypoplasia in the last photo. In the last photo, and you see inside of the mandibular hypoplasia, which is in the golden hard syndrome. There is normal face measurement. This is to see the inner canthal fold. You have important things. This is the between inner canthal fold. See, this is spaces. Then this is the intrapupillary. This is the space between outer canthal folds. So what you need to see is you can take these measurements and actually plot them on this normal, and see the normal. See, also the philtrum has a certain distance. So everything actually, this is only an example for the inner canthal fold, but everything is actually has its own normogram. And if it's more than 2 standard deviation than the normal, then it's abnormal. Yeah, this is the bulbar fissure. Yes. Yeah, this is like upward slanting of the bulbar fissure. So I will go down because there's more explanation there. Okay, this is the spaces already we explained them, but this is I thought it's a nice picture. This is the bulbar fissure. First of all, epicanthal fold is the inner skin fold from the upper eyelid from in the inner corner, which is the same that you see in Down syndrome patients or in patients from Asian origin, like Chinese and other things. Or abslanting, which is you have to draw this imaginary line to just see the slanting of the bulbar fissure. Or down slanting. Okay. The eyes, as we said, you start from eyebrows, you go to bulbar fissure, and the slanting. This is important to check. The length actually also important, and it has also its normogram. Epicanthic fold and eye spacing. Just to know hypertelorism from hypotelerism. There is a rough guide. It's you have to check left palpebral pressure 1, inner canthal distance 1, and right palpebral pressure also 1. Or an easier way to think, it's if you can put an eye between your between the two eyes, this baby is having hypertelorism by default. Okay, and the glove position. Sometimes either it will be deep seated or there will be ptosis. And this is the best from the best assessed from lateral view. Now, within the eye also come the extraocular movement. And this could be with myopathic processes or neurological abnormality. There is ophthalmoplegia that happen in mitochondrial disorder. There is esotropia like Angelman or Down syndrome. Exotropia like in Angelman also and Down syndrome. Nystagmus, you can see it in suboptic dysplasia, and ptosis in Smith-Lemel optic syndrome or cancer. Or abnormal pupil also. Like Lish nodules, which is in Down syndrome, or stellate iris, which is in Williams syndrome. Now, ear position. Normal position ear, it's usually 15 degrees posterior to the vertical plane of the head. Vertical plane, and it's 15 degrees. For you, you have to check if it's anteriorly or posteriorly rotated head, the whole ear shape and structure, and if there's accessory structure, whether bits or skin tag. For the ear, you will see that if it's short, long, anterior or posteriorly rotated, if it's actually all, it's malformed or totally, and lucid, like in multiple genetic disorder. I will not mention one disorder because we know it's lucid in many disorder. Or macro ossia, which is something like golden heart syndrome will have it, or Richard Colling, or see, this is whole abnormal. But when you look for the structure, you will look for the helix, the antihelix, you will see the tragus, the antitragus, and you have to see the lobule. Anything that is not showing the same thing, you have to look for abnormality. If it's not affected and the hair is not affected, this will be in the minor anomalies group because it doesn't affect the function. Now, when the nose, there is 3 sections from the lateral view to superior to inferior, starting with the nasal root, nasal bridge, the breast prominent, broad, nasal tip, broad, flattened, columella, the vertical ridge separating the nostril, wide or overhanging the nostril, the patency and the position, antiverted, and the alar nasal is hypoplastic or not. You can see that the nose sometimes will be prominent or bulbous, like in 22 microdeletion. You might have split appearance in frontonasal dysplasia, antiverted like in corneal delanchation, as Smith-Lemel. This is something like for frontonasal dysplasia. You feel this, there is a bifid nose. Okay. Now we go to the mouth and throat. There is not much things you will see in the throat, but you will see the mouth and perioral origin. You will see the mouth size, shape, the lip shape, the thickness, if there is gum thickness, if there is philtrum definition and length, the jaw position. Also, you will see it, but that you will see it also when you examine the face, and you will see the palate, oral cavity, teeth. There is a frenulum and tongue size, morphology. It's big tongue, or there's thrusting like Down syndrome, or big like picuthid one. There is microstomia, like in something like Angelman syndrome. Microstomia, like in trisomy 18, if there is high arch palate, like in Marfan syndrome. And if there is cleft uvula, like in microdeletions. 22. This is only abnormal shape of the mouth. You can figure out what it is. تمام. طبعا the tongue, this is more of the dentation, but this is something that usually we don't see in neonatology. It's more of the baby that grow more than 6 months. So you would see widely spaced in Angelman, or there is enamel hypoplasia and dental decay في certain osteogenesis perfecta, for example. A tongue, we said if it's a protrusion like Pickwick-Widman, or if there is a thrusting like Down syndrome patient. Now we'll go to the down area for the neck. It could be wide like Turner and Noonan syndrome, could be short like Down syndrome. Webbing you will see also in Turner and Noonan syndrome. That's the webbing. You will see the chest, pectus craniatum, pectus excavatum, like in Noonan, and Marfan have craniatum or wide space nipple like in Down, Turner, or Noonan syndrome as well. طبعا the intral nipple distance also has its own normal. Now the rest of the physical, you will quote the cardiovascular and abdomen. Now you will see if there is a cardiomyopathy associated, and this is more you will see it with the echo, with this further screening. Sometimes arrhythmia happen with like somebody with myotonic dystrophy. Conotruncal defects like something of like George syndrome. Structural heart disease, you can actually mention most of the patient with major syndromes has cardiac as a part of it. Aortic hypoplasia, aortic dilation, hepatomegaly with or without splenomegaly, especially in metabolic type of disease, glycogen storage disease, Niemann-Pick. All this actually you have to finish the examination with. And this is actually on follow seal with in the Pickwick-Widman person baby. This is the same. Okay. Now we'll go to the genitourinary. Now you have to look for the normal. You have to know the normal to go for the abnormal. So if it's ambiguous, you are looking for. You go from the main to the other abnormal. Congenital adrenal hyperplasia is considered the main reason for ambiguous genitalia. There is other reasons, things like Wilms syndrome. Certain genitourinary abnormality will give the block of ambiguous genitalia. There must be sex reversal. There must be a microvenous like in Prader-Willi. You might see cryptorchidism like in Prader-Willi. Trisomy 30, trisomy 18. We could see the hypoplasia flabia majora. She's the female like in Prader-Willi, or also cornea de Lange. You could, by cornate uterus, this is more of the, you will go for the exam and you will see this is an extrophy of Kulwak. Vaginal atresia in Mullerian duct aplasia and other things. You will go to the spine. I will not go too much detail, but you have to see if the patient has a scoliosis, like in neurofibromatosis. You have to see the vertebral segmentation defect. Something like Allergic syndrome will have hemivertebrae. Bacterial association will have vertebral defects, and etc. Deep sacral hair tufting, anomaly of the lumbosacral spine. All these things you have to look up for the spine. The extremities, we know that there sometimes will be a limited range of motion, like the arthrogryposis, contractures, the contraction that the certain disorder that might affect the function, like myotonic dystrophy, and arthrogryposis, also multiplex congenital. This is just a picture. Basically, you have to look for it all. Then you have to go to the hand and feet and find the abnormalities. Polydactyly, syndactyly, brachydactyly, archodactyly, or any cleft foot. These, I will not say, mention all syndromes, but you have to look for them just to see as a part of approaching any dysmorphic baby. Okay, this is already, and you will see rocker bottom, glove feet. The skin, hair, and nail, we already go around it. We said that you will see sparse hair in the ectodermal dysplasia. The hair color is, if it's lighter than expected in certain syndromes, there is hyperpigmentation, there is hypopigmentation, there is a skin color lighter than expected, there is nail dystrophy. All this is important. Okay, we reached the most important part. It's when to refer, when to assume that this baby have one or more major anomalies. Not only one major anomalies, but in up to date, actually one or more major anomalies. In certain books, it's always say 2 major anomalies. You have to start looking for abnormalities. But anyway, certain major anomalies should let you look for different types, the different anomalies, or you have to investigate something like ABSD, conotruncal abnormalities. These will need further investigation by itself, even if it's one. Okay, 3 or more minor anomalies. This is not mentioned here, but you have either one major and one minor anomalies. This also will indicate that you need to investigate. If you have unexplained intellectual disability, whether the patient have dysmorphic feature or not. If you have unexplained growth retardation or failure to thrive. And of course, you can go to chromosomal karyotype if the mother has 3 miscarriages or more. YFTs. What type of testing you have to look for from the history and physical examination should guide you. You could look for specific infection if it's suggested by the patient, whole presentation. You could look for certain maternal autoimmune disease. You could look actually for metabolic disorder if it's also suggested. It should be could be a part of certain testing, but my point is you test according to the baby presentation more or less. Let the patient guide you to the certain investigation. Yeah. Zika virus.
Is part of the others causing microcephaly.
Yes, I know microcephaly.
No, eventually the most important thing is if it's a syndrome or something that to do genetic disorder, you have to go to diagnostic genetic testing. Now this is if there is abnormality in the baby, whether short stature, whether abnormal physique or anything, lab anomalies, or you are looking in the part of the spine anomalies, you have to do the whole skeletal survey. MRI brain, you have to go for it if there is sign of micro or macrocephaly. Sorry, this is by mistake. A macro or microcephaly, and there is clinical suspicion of a syndrome that might be associated with brain anomalies. If you doubt that it could be associated, you can go also for MRI brain. You can do CT. It will help you, especially in torch. There is calcification, and there is suture closure. Ultrasound abdomen. It can also look for the other associated anomaly, and echo is important also. You are looking for a certain collection of anomalies. Now, genetic testing, you go to karyotyping. If there is multiple malformation, and if there is prenatal onset growth retardation, disorder of sexual development, developmental delay, which help, and history of multiple miscarriages, also you have to go with karyotyping initially. This is the most important. You go first to karyotyping if certain anomalies is there, as we said. If it's multiple malformation, something like you think is a trisomy, there is no need to go for example, microarray first. You go from beginning to the karyotyping. Disorder of sexual development, initially you have to go for that karyotyping, because after that you might go to other direction, whether hormonal reasons or endocrinal reason. Then you have to go if you didn't get a chance, but this is not by order. You might go to karyotyping if it's suggested, and no need to go for further testing. Or you can go to FISH if you think that the phenotypes are just specific, especially microdeletions, something like Di George or Williams syndrome, Angelman. FISH and multiplex ligation dependent probe amplification. Basically, you tag a probe to tag certain part of the DNA that you assume it will be present in this patient. And with that, you will find if the patient is positive for whatever you are looking for. It's more specific. طبعا we said if it's specific metabolic disorder, go for metabolic workup. No need to go for other things. Something like mucopolysaccharidosis, paroxysmal disease, and cholesterol metabolism. Now, you could look for single gene mutation analysis. If you are going for whole gene, you can use whole gene sequencing. You can use microarray. This could be in a case of multiple malformation with or without intellectual disability. And you could actually scan most the entire genome for copy number variation. Now, the microarray could fail to find balanced translocation, and if there is a mosaicism, it will fail also to find it. So that time, whole exome sequences is the best.
Actually, there's a trend now that to go if you didn't get if you have multiple congenital anomalies, you did the karyotype is normal, to go directly to whole exome, because the microarray now, the people are more like if it is intellectual abnormalities later on in life, so the people are more going to the trial as a whole exome.
Yeah, but microarray will find a lot of anomalies. Many anomalies that also whole exome will find it. But as we say, certain parts it will fail by default to find it. But it's still you can actually go to microarray if you have, especially if the patient has major malformation, you assume actually that he will find, especially major malformation. Usually microarray will find it. Usually. But sometimes microarray will fail to find certain malformation. Now, intervention, it's according. Yeah, you have a cardiac, you would refer to cardiac. You have a surgical cause, you have to refer to surgical. Genetic counseling is important. And طبعا genetic diagnosis, it will help you, يعني it will guide you to go for everything initially. يعني. Genetic diagnosis when feasible. Most important that you know about genetic counseling is you have to inform them that deformation or disruption is a low risk of recurrence. De novo chromosomal abnormalities have some risk of recurrence. Certain familial chromosomal arrangement depends on the certain time. Single gene mutation, also the risk of recurrence will vary, and it's mainly to the mode of inheritance will go. Follow up, you have to follow up any patient with dysmorphic baby to assess his growth and development, to study the course of disease, to monitor for known or anticipated associated complication, to offer a newly developed diagnostic test, to offer therapeutic option if it's available or newly available. And sometimes you might miss, but the phenotype sometimes could evolve with age, and reassessment later could help in undiagnosed cases. And the reproductive risk should be discussed with the family. طبعا referral to genetics, if you are suspecting of genetic disorder, actually you have to refer with whatever we are saying. If there is single major or multiple major or multiple minors, but you have to refer. Family history, especially if there's specific birth defect, and you think that there's possibility of recurrence, you have to refer to genetics from beginning, and the other refer for plastic surgery or other things accordingly. Yani according to the birth defect, you can go for the referral, whether plastic surgery, whether neurosurgery, whether orthopedics, according to the defect. This is my references. Thank you.
Thank you for your informative and detailed information. Okay, so the floor is open for the discussion.
Morning, everybody. Thank you very much. This very nice presentation, Dr. You turned a very moving topic into a very interesting summarized slides. Thank you very much. Well done. Probably two comments. One of them, this can be easily transferred into some modification or guidance for us with some algorithm probably how to approach these kinds of cases. I'm not sure if you are ready to go there, but I find it a very good opportunity to transfer this into our guidance. Thank you very much again.
Thank you, Dr. Yasser. Any further comment or question, please?
Thank you, Anoud.
So we can conclude the session. Thank you so much for attending. See you next week, inshallah. Assalamu alaikum.
Thank you all. Thank you.
Thank you very much.
Thank you.